Good afternoon or good evening, wherever you're tuning in from. We're so excited to have you on again for another NSWAC and Walk Institute Continuing Education webinar series. Again, this is one part of our multi-part series on wound care strategies for keeping the patient at home and in the community. This is our third part, and today's presentation is going to be on determining lower leg etiology and patient navigation. And we have with us today our amazing guest speaker, Dr. Gary Sibbald. And before I introduce our guest presenter today, just a couple little housekeeping items and a little bit of a icebreaker. You can see people already putting it in the chat, but if you want to click that chat button in your Zoom toolbar, you can let us know where you're tuning in from across Canada or abroad if you're tuning in from outside of Canada as well. My name's Troy, and I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada, and I'm tuning in from Ottawa. Just so you all know, for today's presentation, we are going to be doing a number of polls, so make sure to keep your eye on your screen as we go through the slides. We'll be asked to answer a few questions here to get that audience participation up, so do stay looking for that. We're also going to be doing a Q&A period at the very end as well, so make sure to click that Q&A button. Rather than the chat, we prefer to put them in the Q&A box. That'll keep us organized and keep the conversations going during our Q&A portion. We're also recording today's presentation, so if you need to go watch this back again, or if you got to leave during the webinar and want to see it again, we will have it available on demand on our NSWAC conference or NSWAC website. And all those who are in attendance today will be receiving a certificate of attendance. So just give us a couple days and we'll get that to you in your email inbox. So without further ado, I'm happy to introduce our guest speaker today. And we're honored to have Dr. Gary Sibbald with us. And Dr. Sibbald is a dermatologist and internist with special interest in wound care and education. He's the founder and executive director of Woundpedia and the lead of Project ECHO, Ontario Skin and Wound. Additionally, Dr. Sibbald is a professor of medicine and public health at the University of Toronto and a clinical researcher with over 200 publications in the field of wound care. Dr. Sibbald is the co-founder and course director for of the International Interprofessional Wound Care course and serves as the director of the Masters of Science in Community Health Prevention and Wound Care at the Dalla Lana School of Public Health at the University of Toronto. He's also held several prominent leadership roles, including serving as the former president of the World Union of Wound Healing Societies and as co-editor of the Chronic Wound Care textbook. Today, Dr. Sibbald is going to be sharing his expert insights on the common etiology of lower leg wounds and how this applies in our community as well, of course. So without further ado, I'm very happy to pass over the mic and the slides to you, Dr. Sibbald. Thanks so much.
Okay, thanks, Troy. And I'm very glad to be here to talk about a subject that's near and dear to my heart, lower leg ulcers, etiology, and patient navigation. Next slide. My conflicts of interest are mostly with the Ministry of Health 2 days a week with Project ECHO. I've also used chymoseptine as a sponsor to go to the Philippines in 9 of the last 12 years, and Perfuse Meditech is the owner of the Gecko, which is a predominantly Canadian-owned device that I will talk to you about a little bit later. Next. We are going to examine less common leg ulcers, the kind that are missed, and it is important to explore treatment options, an approach when healing is not possible, assess patient navigation and the effectiveness for healthcare system change, and evaluate muscle pump activator device, which is called the Gecko. Next slide. What do you think the most likely diagnosis is here? You see a black area. It's around the posterior calf, and if you look down a little bit further, you'll see an ulcer too over the Achilles tendon. Is this traumatic, bullous pemphigoid, hypertensive ischemic ulcer, vasculitis, or necrotizing fasciitis?
Wait a couple more seconds.
Okay, so the most prominent answer is vasculitis at 38%, and then at 22% we have traumatic and hypertensive ischemic ulcer, at 16% necrotizing fasciitis, and 1 vote for bullous pemphigoid. Well, in fact, on the next slide, This is a hypertensive ischemic ulcer. It's often a painful wound with a necrotic base. It's often on the lateral dorsal aspect of the calf or Achilles tendon. Patients usually have hypertension and sometimes diabetes, usually type 2. Pain is not exacerbated by exercise and leg elevation, so it's different than the large vessel ischemic pain. Diagnosis is history and clinical confirmed. You need a deep elliptical skin biopsy, the wound bordered to fascia. Surgery is the most rapid and effective treatment, taking away the dead tissue, necroscopy, and plus or minus a skin graft. Next slide. And they're extremely tender. Sometimes you'll see a livido or a net-like pattern around it. You biopsy and you see an infarct and you need a deep wedge. But this is medial calcification of the blood vessels, and they obviously get thrombosed and calcified plate of skin. So if you put a gloved hand on and you feel around these, you'll feel this very firm calcific plate. And you can use an ultrasound to identify this. And we did publish in the Journal of the American Academy of Dermatology some years ago. If you haven't seen this, you don't recognize it. And you've got subintimal fibrosis, stenosis of the arterioles, and thrombotic occlusion. And that leads to, when you get your superficial vessels occluded, you get cutaneous necrosis or black skin. Next one. Okay, what's the most likely diagnosis here? In the last one, you have to get rid of the lesion and you have to treat pain, usually is the most important thing. What's the most likely diagnosis here? Traumatic ulcer, bullous pemphigoid, pigmentary purpura, vasculitis, or necrotizing fasciitis. What do you think here? Okay. Tell me when it's cut off.
You should be able to see the results in front of you now.
I can, and it shows tied with pigmentary purpura and vasculitis, and the others are lesser. And in fact, in vasculitis, it can ulcerate and break down. In pigmentary purpura, it usually does not. And they're usually all uniform. And you see here at least 3 or 4 small ulcers. And so that you know that there's quite a bit of damage to the blood vessels. In pigmentary purpura, it's just leaking, and it's usually much more uniform than this. And vasculitis is more common in the lower legs, where you get the most reduplication of basement membrane, you get cooling of the blood, you get trapping from gravity, and you get thickening of the blood. And that's where immune complexes really get trapped and cause the lesion. Next one. And you see in the upper left corner a superficial vasculitis. The other 3 are more deeper. The left lower would be an area of the mid-dermis and to the subcutaneous junction, as would be the right lower, where you see nodules. And the right upper, it's a lividoid pattern, and this would be a little bit deeper type of pattern, but it also has some ulceration, as you can see. Next one. Here's just a little bit different picture and showing one superficial, the other's a deeper vasculitis. Next one. History. All patients, you need to know previous drugs, illness, and we do know commonly that joints, liver, and kidney. Systemic, uncommon is GI, heart, lung, and brain. And we do lab tests, including complete blood count, liver and kidney function, Hep B and C, HIV, and other. Skin biopsy should be for regular histology, immunofluorescence. You want to pick a new lesion, and if you close your eyes and feel it, it should be palpable. And you draw a circle around it, put the local anesthetic in, punch, suture. If we're doing a lupus screen or collagen vascular disease, and sometimes this can relate to infection, but in the lupus screen, you'll do an ANA, rheumatoid factor, ENA complement, and anti-DNA. Selected patients, you may screen for cocaine or levamisole in somebody that's got intravenous drug use. Then you would certainly look for hepatitis C there and malignancy screen. And lymphoma seems to be the most common with vasculitis. Next one. First line, observe, remove the cause if it's drugs or infection. Colchicine, used for gout, but it's a good anti-inflammatory for neutrophilic infiltrates. So is dapsone, but patients get a lowering of their hemoglobin, sulfasalazine much less. And if you're going to use dapsone, we need to do a glucose 6-phosphate dehydrogenase. That's a test to make sure they're not overly susceptible. Non-steroidal anti-inflammatories, but you don't want to use these in anybody over 65 or use it with caution in that population. Second and third line, oral prednisone, immunosuppressive drugs, including cyclophosphamide. Sometimes if it's itchy rather than painful, we'll use antihistamines. Pentoxifylline or Trentol is an interesting drug. It's a xanthine, so it has effects like coffee, but it increases red blood cell contractility. It's anti-inflammatory, and it's fibrinolytic. It helps get rid of the woody hardness. And sometimes intravenous immunoglobulin are used for systemic vasculitis where other organs may be involved. Next one. Okay, what do you think here? Is this traumatic, bullous pemphigoid, pigmentary purpura, cellulitis, or necrotizing fasciitis? What is going on here?
And it looks like we got a bit of a consensus, so I'll share the results for you now.
Okay, although this may look like bullous pemphigoid, there are some other characteristics which it is not. And only 5% of you got this right. These patients are generally systemically ill. If you look around the margins, you'll see that they blend into the normal skin as you look at the far margins. And there is a lot of hemorrhage within the blisters. And this is a deeper phenomena. This is life-threatening and limb-threatening, and this is necrotizing fasciitis. And this is an important thing to recognize. If you see hemorrhagic bullae, what you don't see is that they're unwell. And you see the cellulitis, you can usually draw a line around it. But if you look at this, it's going in a zigzag pattern, and there are streaks extending out from the zigzag pattern. So this is one that I want you to cement in your mind. If you want to take a picture of it so that you remember it, I'm fine with that, because we really do want to impress upon you that this requires a surgeon to see. They have to go down, and often the extent of this is greater than what you see clinically. Let's look at the next slide. It's fulminant, acute, and subacute. It involves the lower extremity. It blends into the tissue, tense, shiny skin. It can affect the genitalia, and then it's called Fournier's gangrene. Next. And it's a painful cellulitis with a hemorrhagic blister. Limb and life-threatening. Group 1 is polymicrobial. If it's monomicrobial, group 2, it's most often strep. You need to give the antibiotics, they need to be IV, and they need to get to the operating room ASAP. Next. Cellulitis, see, you can draw a line around the top and the bottom of this. Oral or parental, that means IV antibiotics. Swab if an open area. Acute wound, it's usually gram-positives. In chronic wounds, you look for gram-negatives and anaerobes, even without immunosuppression. but don't treat the swab, treat the symptoms and signs of infection. Next. What do you think the most likely diagnosis is here? A traumatic ulcer, bullous pemphigoid, pigmentary purpura, livedoid vasculopathy, or venous stasis? Enter and sign in, please.
Just leave it for a couple more seconds. And you should be able to see it now in front of you.
Okay, the majority said venous stasis, and although this can be seen in venous stasis, you don't usually see the extent of involvement you see here. It's going right down onto the foot instead of centered around the malleolus. And you see the atrophy blanch, and you see very prominent small blood vessels, and you can see in the further away picture, venous varicosity, the starburst veins that go down from the medial malleolus. Let's look at the next slide. And this is just a close-up of the livedoid picture and the extension. And if you see it at the base of the toes, that usually indicates it's more systemic. And this can be when you start to get, and you can see early necrotic areas, 2 or 3 with black spots beginning to appear in the right-hand picture. And let's go to the next one. Painful ulcerative condition, atrophy blanche, smooth white scars. So that's complete atrophy. You've lost your blood vessels, or you've lost your blood vessels, you've lost your sweat glands, you've lost your reedy ridges, etc. Surrounding telangiectasias, those are thread-like red blood vessels. Hyperpigmentation, central shallow ulcer, but they're difficult to treat because they're really painful. Do a skin biopsy and you do histology, a regular one and one for immunofluorescence. Wound and tissue cultures. Lab investigations cost about $800. So I don't do the factor, anti-factor 5 and 8 because the treatment is the same. And you can do complements, or you can do a CBC, liver and kidney immunoglobulins. Non-invasive arterial or venous ulcers. And I think that here, it's not the deep areas that are involved, it's the very superficial vessels. It hurts like hell. Next. First line is elevation, aspirin, usually low dose, 81 milligrams. Pentoxifylline is Trentol, and we talked about that in the first case. 400 milligrams 3 times a day. There is a limited use in Ontario. I use the 76 rather than the venous 529 because it's good indefinitely. The 529 only for 10 months. Anticoagulation, you use low-dose Xarelto, rivaroxaban, 2.5 milligrams twice a day. Hyperbaric oxygen sometimes used because it's ischemic. For pain, you often need to treat both the nociceptive pain, so that's the pain that's like a toothache, versus neuropathic pain is spontaneous rather than stimulus-related or trauma-related, and it often has burning, stinging, shooting, stabbing, and the treatments are different. We sometimes for this use sulfasalazine, 500 milligrams 3 times a day, or intravenous immunoglobulin, IVIG. Next one. Panichi red hive-like reaction over the legs and subsequently the rest of the body. The rash has been blistered in the last couple of weeks, and new blisters are occurring every day. Every day. What do you think this is? Impetigo, bullous lichen planus, a burn injury, bullous pemphigoid, or is it epidermolysis bullosa? We'll get you to vote.
Ready, and you should be able to see the results now.
Okay, epidermolysis bullosa 49%. Maybe I should have left that in here, but the epidermolysis bullosa is a genetic disorder. You often see it shortly after birth, and there are 4 major subtypes and over 20 variants of it. But this is extremely itchy. It's more common in the elderly. You see a red area that's impetigo-like, but you see intact blisters. They're not bloody like before. The erythema is a hive-like erythema. Yes, you can draw a line around it. It's not, so no hemorrhage, and the erythema is quite distinct, and it's quite itchy rather than painful and being sick. Bullous lichen planus, not so much erythema. Bullous impetigo, not such large areas involved, and usually younger individuals. Next one. And the telltale sign is this fluorescence where you can see it at the dermal epidermal junction. You can see the line that goes down the rete pegs and ridges, and this is cut in cross section, so you're seeing the ridges at different levels, and the immunofluorescence is diagnostic. Elderly, autoimmune, subepidermal, blistering disorder, tense blisters on a red base. Can be localized or generalized. Localized, I've seen mostly on the legs. You need regular histology, but a new lesion at the edge. If you do the blister, the top will fall off and you won't make a diagnosis. You can also order, in Ontario anyway, indirect antibodies for pemphigus and pemphigoid. And they often have an IgE, which is one of the 4 IgG, A, M, and E. And the IgE level is often elevated when this is active, whereas the indirect antibodies don't relate specifically to disease activity. Next one. And here you see the blisters that are partially treated. The very worst thing is these patients come in and they're all treated with inidine or an iodine type of preparation. Iodine's pro-inflammatory. This is an inflammatory disorder. Please don't use iodine. And, you know, they're not going to be hot to the touch if you use a gloved, and they're going to be itchy rather than painful in general. And this is what it looks like with partial treatment. So try not to put iodine on these people. Next one. Ultra-potent steroids will often use clobetasol, which is 12 times hydrocortisone. Put it on a gauze and lay it on. Interlesional steroids if we've got too few. But the drug of choice now is doxycycline, and using 200 milligrams a day. Systemic steroids, when that fails, 0.5 milligrams per kilogram per day. So if somebody weighs 60 kilograms, you'd use 30 milligrams. And then if that fails, we use steroid-sparing agents, azathioprine, mycophenolate mofetil. Dapsone's more of an anti-inflammatory, and methotrexate, which the other 3 are immunosuppressive type of drugs. And next slide. Here is, and if you want to take a picture of this, this is an important slide. This is the blister study, and if you Google blister study and Lancet, this will come up. It took these people from 2009 to 2013 and 50 centers across Europe to do this study. And to enroll 253 patients, 132 took doxycycline and 121 took prednisolone. And look at week 6. And what you see is that 3 or fewer blisters in 83 out of 112 on doxy, 74%, 92 out of 101, 91% with prednisone. But there was an expected adjusted difference of 18.6% and predefined 37% margin. Why? Look at the next line. Related life-threatening events at week 52. So that's a year out. It takes a while to control these people. 18% in the doxy group, but 36% in the prednisolone group. And 11 patients on prednisone died, and partially related to the treatment or the disease, where only 3 died in the doxycycline. So it's 3.6 times more likely to experience death on prednisolone. I may, if they're really bad, give them prednisone like I would for acute poison ivy. And if I start it with 0.5 milligram per kilogram or 30 milligrams, I'd reduce by 5 milligrams every 5 days. So there would be in total 6 reductions or 30 days of prednisone rather than them being on it for a whole year, which many of these patients required. And it's much, much safer. But you really need to make this diagnosis. And the worst thing possible is to use wound dressings. Okay, the worst thing possible is to use wound dressings. Next slide. And here you see the differential diagnosis. Take a picture if you like. Arterial, venous, or mixed. Infection, osteomyelitis, or cellulitis. Inflammatory. We showed you the vasculitis and pyoderma gangrenosum. In other talks, I've talked about basal cells and squamous cell. And a basal cell can look like granulation tissue. And if it's above the gaiter area, the lower third of the calf or on the foot, I think Michael Stacey, who you've probably heard in some of these lectures, has shown that only about 15% of venous ulcers are in these locations. So this is something that you really want to watch and be sure of. So if an ulcer is not healing in 4 to 12 weeks, an interprofessional assessment or a biopsy of the edge is needed. And I'll put this in perspective shortly. Next one. And what's patient navigation? This is something with Helen Arpathanathan in Waterloo, Wellington, talked me into this. Home and community care support services. They're now called Ontario Health at Home. Also offered evidence-based practice of care in alignment with Ontario Health, wound care standards, which we did, and Wounds Canada during COVID. Lockdown home and community care support services implemented a pilot project focusing on patient navigation, improving complex wound outcomes. Next one. And what we did was we virtually co-navigated an in-home team, and 3 NSWACs actually went in and did assessments based on Wound Bed Prep 2021. The primary treating nurse, the patient, a family member, or a close friend. We looked at getting as close a diagnosis and treatment plan as possible, and during the COVID-19 pandemic. And 20% of these patients, and I've already said this, represent 80% of the cost to the healthcare system. So we need to do something better. Next. And how did we get patients? Well, care coordinators picked up patients who completed a wound clinical pathway without any wound closure. And palliative patients with complex wounds, high resource utilization patients, or patients without a diagnosis are best practice. Next slide. And I was the consultant. Helen was the organizer, along with Jane Hyde and along with Timado Adatola. And we looked at these patients. We interacted with the care coordinator, the primary nurse, the wound care nurse specialist, the primary care physician, the pharmacist, and the family. Next slide. Care coordinator identified them, stalled patients, wound care nurse completed the assessment, communicated to family doctor, and wound physician expert. I reviewed this. We had an hour interview with the patient in the home and the family member and the primary nurse. Next one. Nursing navigator and patient coordinator implemented a plan. If we were doing specialist consultations, we'd organize them within 2 weeks. Navigation with pharmacy for dosage adjustments, and we often got them in dosettes. Foot care specialty, dietitian, or social work as required. Follow-up to adjust diagnosis, healability status, and, were they healable, maintenance, or non-healable? And improvement on patient quality of life if we couldn't heal them. And we developed a discharge team for prevention strategy and improved patient quality of life. Next. There's the 2024 paradigm, same as this. We went through all 10 steps, and hemoglobin A1C, blood pressure, and screening for the high-risk foot if this is a person with diabetes, all saves money to the healthcare system and improves patient outcomes. I've talked to you before about using the audible Doppler instead of the ABPI. I've talked about NERDs and stonies for infection, and we've looked at plantar pressure redistribution, even with simple measures. We need to control pain. We need to look at the patient support system and their medication. Is it healable? Is it maintenance or non-healable? Well, most of these were all maintenance or non-healable, but sometimes we felt we could change it to healable. Local wound care, we looked at the actual local ulcer documentation. We looked at debridement options. We looked at the NERDs and stonies. For healable wounds, it was moisture balance. For non-healable or maintenance, moisture reduction. If they weren't 30% smaller by week 4, weren't going to heal by week 12, do we need a skin biopsy, special investigations, or the interprofessional team? Well, in this case, we're already there. And we might consider an healable wound that stalled some of the advanced therapies like the gecko, the skin graft, electrical stimulation. And we always want to reflect on how we can make the healthcare system better. Next one. What we did was in 29%, we closed the wound and discharged them. But we need it with the discharge as support structure. 66% had reduced wound area. When we looked at this, we were able to reduce nursing visits in 73% and reduce supply usage by 77%. We reduced pain in 73%, but with NERDs and stonies, NERDs for local or covert infection, stonies for deep and surrounding infection, and appropriate management, we improved 79% of these people. And we did 48 patients. And this is what we want specialty teams, doctor, nurse, and allied health to do in home care moving forward. Next one. So wound preparation was an excellent tool to ensure effective management with stalled or suboptimal wounds that validated the wound bed prep and collaboration with the interprofessional team, benefiting both patients and the healthcare system. And a couple of years back, this won the best poster for Helen Arpathanathan at NSWAC. Next one. Let's look at a case, and this is going to be interesting. Here's a guy that came to me with 4 black toes and some crusting on his foot. It was so painful, I could not touch it. I couldn't really do debridement that first visit. Next one. He's a male between 70 and 79, Caucasian, partnered and married, urban setting, retired senior executive in insurance, peripheral vascular disease, congestive failure, chronic anemia, alcohol-related hepatitis. He quit drinking 12 years ago. Past surgical history of bilateral femoral artery stent in August of 2023. And you get after this reperfusion injury. No allergies and no alcohol. He used it occasionally. He smoked for 50 years, up to 2 packs a year. So he had 75 pack years of smoking. and he stopped in August of 2023 when they wanted to amputate his leg below the knee. Home nursing care for 3 to 4 months, not healing. First seen following his bilateral femoral artery stents with necrotic wounds to the right foot. Pain off the map, 15 out of 10, unable to touch. Sleep sitting on a couch with the leg down due to severe pain. Not able to go upstairs and can't drive. First visit, he was changed from saline compresses to hypochlorous acid. Treat it with the Gecko device, and I'll show you what that is, and a nitro patch. So 12 hours a day of Gecko and 12 hours a day of nitro patch. And next slide. And we moved his nitro patch from his chest down to his foot. What is the Gecko? It is positioned at the fibular head to stimulate the common perineal nerve. It's worn for 12 hours per day, 7 days a week, and each device lasts 2 days. There are 3 electrodes that provide comfort and ease of fitting, 10 levels of stimulation, of the perineal nerve. Wristwatch size, 10 grams in weight, battery operated, self-contained and self-retentive, and it lasts 48 hours. Next. How much do you think the Gecko device increased the speckle imaging of peak venous velocity over the baseline? So how much flush do you think we got in the foot and ankle region with the Gecko? Did it increase at 50%, 100, 150%, 200%, or 200% only when combined with compression therapy? Let's get you to answer, vote, and sign in, please, on this one. Andrew, just be prepared. I may have enough time for the EB segment.
Alrighty, you should see the results in just a second.
Yeah, and it looks like we're all over the map here, eh? Well, let's look at the answer on the next slide. And there's the Gecko at baseline, and let's see the flush. So you see a little bit of flush. And once we turn on the Gecko device, let's look at the flush. And it's 200 times greater. And look, it's actually perfusing the whole area to a much greater extent. Next slide. And Professor Keith Harding and group did venous ulcers. That's why this is included here. He had a hypothesis that the increased flush would help these patients, and we looked at the results. Next one. So what happened at screening, patients were put on compression. At week 4, they were randomized, and if the ulcer hadn't decreased in size effectively, they either got compression to be continued from week 4 to week 8, or they got compression with the Gecko. And this was then applied between week 4 and week 8. And then there was a follow-up at week 12, 16, and 20. Next. And this just shows a patient with standard of care, and you can see the ulcers much the same at the end, and a patient with the neuromuscular stimulator and electrical stimulation. And you can see at the end, this is almost healed at week 8. And venous ulcer operation, that they healed at 2 times the rate of standard care alone. And it's interesting, the increased trajectory increased even after week 8. Daily device adherence was 94.7%, didn't interfere with activities of daily life, and reported pain was reduced with the Gecko. There's transplant studies in over 200 patients done in London, Ontario, and it's post-renal and plus or minus pancreas. And infection rates were decreased by 50% with the gecko compared to the standard of care. And the transplant incisional surgical site healing was higher with the gecko and standard of care. So it mobilized more fluid and decreased weight more. Next slide. And this is our patient. We used EMLA, which is eutectic mixture of local anesthetic. And after I put this on, this was in October, a month later, I was able to remove some of those necrotic caps conservatively. And there was frank pus under one of these caps, the one on the third toe. And pain after walking or standing was stabbing, shooting, tender, 8 out of 10, got better. I had him on pain medication. Only the fourth toe involved a yellow discoloration and surrounding erythema. Used the gecko, moved his nitro patch down, and we were able now to put 2V grip on his leg. He didn't tolerate that before. Follow up with chiropodist that advised a swing gait, where you swing your leg around, walk with the other foot, and swing your leg around. And March 21st, 2024, bone was exposed on the top of the fourth toe. He had monophasic sounds, and we restarted him on Moxie at that time. Betadine, inidine indefinitely between the toes and more on the fourth toe. Next one. And as we went along and we did more debridement, we actually saved all the toes and got him out of the wheelchair and got him walking. Next. And you see he's on a plethora of medications, including pentoxifylline, acetaminophen and hydromorphone before dressing change, PRN. The acetaminophen, 1 gram twice a day. Pregabalin was used as the treatment. He was up to 100 milligrams. He's now off, 100 milligrams 3 times a day, and nortriptyline 10 to 30 at night. And those are number 1 and 2 on the Canadian neuropathic pain guidelines. Moxiflox 400, antibiotics depending on the culture varied along the course. He had some TB in his lungs, and maybe from the smoking and previous exposure. And he was, for part of the time, on rifampin, azithromycin, ethambutol, or triple therapy, which he took for 1 year after the clinical signs of the lung disease. So this guy had another disease going on at the same time. Next one. Nutrition. If you haven't seen the Canadian nutrition screening tool, this is great. No blood test, nothing. Have you lost any weight without trying in the past 6 months? No. Have you been eating less than usual for greater than a week? No. 2 no's, you don't have to. You need 2 yeses for a nutritional consult. Validated tool in the hospital setting. Good thing for you to pick up. Next. You see hemoglobin A1C was fine. And you don't want it too low in older people, because if they go hypoglycemia, they knock off some nervous cells. His hemoglobin was a little low, but over 100, we should still get healing. Creatinine was in the high normal. Liver function was normal. Vitamin D was a little bit low, and we supplemented that. A, D, E, and K are fat soluble, so it should be with the meal. And I think we gave him 3,000 international units with supper. Next. Okay, listen to his sound now and tell me what it is. Get that in the field. We got the... And look at that foot now, eh? Okay, let's get you to vote.
Right, and I'll share it now with you.
Okay. This is probably either a monophasic, but there's a hint of a second one, so that the biphasic may come into this. And you know what? This is just reperfusion. This is not a great arterial supply, but I think with his bypass, we effectively had healing. Next one. And pedal pulses on the right, yes, the left, no. Audible handheld Doppler. We called it monophasic, but there's a hint of a biphasic sound in there. ABPI is not necessary, and to be gripped bilaterally is what he tolerates. Next. He is really a maintenance wound, but sometimes you can heal a maintenance wound, and we did. And you might call it healable if you called that biphasic. Next. And you see at the beginning, he had every sign in the book. He needed antibiotics, and we gave them to him when he needed them. Next. And he had allodynia, and that's an exaggeration of a normal response. Couldn't touch his foot until he got on the neuropathic pain medication, and he's weaned himself off, and he's in shoes now. And probably wearing sandals with Velcro is a good idea. Next. What she had, and look at the improvement in that foot as time goes on. Next one. And you can see here the fourth toe was the laggard, and it did have some abscess material behind it, not the third. Next. Now he's finished the gecko. Home nursing stop. Pain is sporadic. Every once in a while he gets a stabbing pain up to 8 out of 10. It lasts only a few seconds, and he can carry out no visible open areas on the right foot. Fourth toe healed, and there's no probing to bone, and you see his tubie grip. Next. And he's got the patient family wound care team, chiropodist, respirologist, and vascular surgeon. Let's hear him talk to you.
Yeah, so Greg, if you're looking at this from the beginning to now, what's your functioning like now? You're walking. Did you bring your cane today?
No.
No? How about your pain level? What's that?
My pain level is if 1 is none and 10 is plenty, I'm sitting at about a 2 max.
Okay.
Very, very rarely is it occurring. My functionality in terms of walking, I'm walking virtually normally now. The only thing, the drawbacks are getting back some muscles, which I don't have.
You got it.
I also have some lung capacity that I'm working on, but that's a completely different issue. But overall, it's like night and day compared to where it was 12 months ago.
And you had the nitro patch, which we're still using, but you also had the gecko device.
Yes.
And did you have any trouble wearing it?
I had trouble with neither one.
Mm-hmm.
The gecko, I ran at about an 8 in terms of intensity. And I found that after a relatively short period of time, the only time it was distracting is if I decided to go horizontal and try to sneak a nap in midday. The rest of the time, it was like it wasn't even there. And the nitro patch, I just had to get some reminders put out to remove it. So neither one was invasive in any way, shape, or form to me. I know some other people may have found it distracting, but not in my case.
Okay. I did notice today that your right foot was a little cooler than your left, and you've had one episode since our last visit, but it lasted only 5 seconds. But it's making me a little reluctant to get rid of the nitro patch. And, you know, your dose of pregabalin is minimal. I mean, I think you're on 425s right now, and we'll go down to 3.
Right.
So 75 milligrams, and the maximum for that drug is 600 milligrams. So I think, you know, we're in the bottom rung. And for the toothache or nose-receptive-like pain, you're on 1 gram in the morning and 1 gram at night of acetaminophen, and that really for anybody over 65 is the preferred thing. So I don't mind you reducing, but I think that we're in a good zone.
Well, you got me there. That's for the record. So yeah, we're doing very well in terms of pain management.
I think it's great. Okay. And listen, if you were giving somebody else advice if they were asked to get their toes taken off, what would you tell them?
Toes taken up?
Taken off.
Taken off. I would tell them to immediately seek help from the medical profession and zone in on the Etobicoke area if they are looking for any assistance. But seek help immediately. There are options available that really aren't well known out there in the market.
Mm-hmm. Okay. Well said.
Thank you.
Anything that you would say?
No, it's just a miracle. Taking a look at his toes, especially today, and looking back at those pictures, it really truly is a miracle. Thanks to this office.
Okay, thank you.
All right, I do see a few questions in the chat, and there are some hands up. And yes, the fifth one was bullous pemphigoid. Should the blisters be de-roofed? I do not de-roof them. I use a needle that's clean to let the fluid out, but we leave the top on. What would you use topically? I often, if I have to put something on the top, it is a prescription item. It's limited use in Ontario, 383. I would use Protopic, put it on gauze and lay it on there. Around the ulcers, if you've got the redness, we often use a topical steroid, and you can use a cream or an ointment. Clobetasol is 12 times hydrocortisone. Don't put it on the face or in a fold area. If you want to use something just neutral, you could really use Vaseline gauze or Bactigrap. The chlorhexidine stays in the gauze and it won't be inflammatory. The gecko requires in Ontario at the moment special authorization, but it is a Canadian company and we hope to promote it so that it's more available within the healthcare system. Troy, are there any other hands up?
What we can do here, yeah, if you're okay with this here, maybe I'll start with, it was Gurpreet who had their hand up first. Gurpreet, I'm going to allow you to talk here if you do want to ask a question briefly. Just make sure you click unmute there and that your background noise isn't too crazy, but you can go ahead and ask your question if you'd like right now. And if that was just a mistake, you can just lower your hand as well. I know sometimes you do that instead of doing the thumbs up reaction or something, so no problem. What I'll maybe do here is while we do that, Linda, I'm going to allow you to talk. I see your hand is up. So Linda, if you'd like to go ahead, you may unmute and ask a question. Okay, that was a same thing there. I think they just lowered their hand, so no problem. Okay, so let's maybe try one more time. Annette, I think you put it on since I started talking about this. So Annette, please go ahead and ask your question.
You know what, Troy? I've got another segment that I'm going to insert here, and it's impactful.
All right, you know what? Let's go ahead and do that then. What we'll do is anyone who does have any questions, please put them in the Q&A, chat or Q&A box, and we'll get to that after. Okay, please go ahead if you're ready.
Okay, so this is looking at epidermolysis bullosa, and it's Deanna's story. Next. And there are, the dystrophic EB is dominant or recessive, and it's abnormal type 7 collagen. And type 7 collagen is the anchoring fibrils that hold the epidermis and the dermis together. They get skin fragility, their hands and feet fuse together. You can see that in the bottom with time. They get microstomia, a very small mouth opening, difficult oral hygiene, dental carriers. When they get in their 20s and 30s, they get aggressive squamous cells, and that will often kill these individuals. Next one. And okay, go on to the next one. Okay, go back. I guess that's to play Diana's video. So let's listen to Deanna. Deanna developed squamous cells and had her right hand amputated and her right buttock. And then she developed a squamous cell in her right foot. And she decided that nobody was going to chop anything else off. And let's listen to this.
Deanna, you have epidermolysis bullosa, recessive dystrophic type, and you've had lots of challenges with the medical system as time's gone on. What would you advise doctors and nurses in wound care looking after this condition? How can they help you in the best possible way?
I think as a patient with RDEB, I think the best way medical professionals in any capacity could help is provide options and really listen to what the patient is saying. And the biggest thing is, like, I know my own body the best, and so does everyone else. And just listen and work together as opposed to following what has worked in the past. I think it's beneficial and I don't know what the word I'm looking for is, but it's important to give the patient a choice in terms of which treatment options are available, whether it be wound dressings all the way to squamous cell carcinoma treatments, which is something that develops quite quickly with patients with EB. I've dealt with 4 bouts of it now in the past 6 years, and I've tried many different methods, and I think the biggest challenge was just managing my daily life and living my best life I could possibly live. And don't treat the patient in any, don't sugarcoat things is what I'm trying to say. It's a tough thing to deal with, but at the end of the day, we have to live with it and accept our own lives and make the best of them. So I think just offer different avenues of help, different pain methods to control pain, and just help the patient work together to live their best life.
Okay, go on. So when we looked up, let's just see what the data showed. We looked up squamous cell and EB, and there's a high likelihood of metastases and mortality. Malignant melanomas, basal cells can also occur. Surgical excision is most common. No difference, though, in survival between different initial management options, excision, amputation, and other modes of treatment. And so we agreed with Deanna we weren't going to take her leg off, and she would come in every 6 weeks or so up into her death, which was from a respiratory infection, and take things off. And we found squamous cell in most of them at the beginning and very few of them once we had done a number of procedures. And although we'll go a little bit over, Troy, on the next one, listen.
Whether it's the finger painting of a child or a gallery masterpiece, the power of art to heal and to inspire is undeniable. Why does the simple stroke of a brush hold so much power? Allow me to introduce you to artist Deanna Molinaro to share the secret.
I like portraiture because I find people very interesting, but I also like surrealism. I tend to blend surrealism and realism because life is surreal. There are moments where you don't really know what to expect or what's coming next, and you kind of have to live each moment to the fullest. My name is Deanna Molinaro. I am an artist from Hamilton, Ontario, Canada, and I was born with recessive dystrophic epidermolysis bullosa. So RDEB is the second most severe type of EB. Any slight trauma or just simply the progression of growth causes the skin to shear and blister, leaving behind wounds equivalent to third-degree burns. I was born in '92. My parents had no help here in Canada. They had no idea how to treat me. But over time, my parents and other parents like them, or someone being close to the cause, have helped change that. The community has grown exponentially across Canada and across the world. So yeah, it was just so different. I've been able to make so many connections with other individuals like myself, and it's so comforting to know that other people can understand what you're going through and you're not alone. As a child growing up with EB, my parents were very willing to let me learn what my body was capable of doing. So I remember always just drawing as a kid because I couldn't build with Lego blocks. I couldn't pull them apart. So my parents giving me crayons and a paper and pen and something that I found I could occupy myself with for hours. And then it just became a passion and something that I've always loved to do. My family and I, especially me and my mom, we have a really close-knit relationship with her being around me. For instance, every day she'll help me, take me to the washroom, put on my makeup, fix my hair, put on my wig. She's my superwoman and she does a lot for me. I'm fortunate to have people that care for me and are willing to kind of adapt their lives to help me live my own. Growing up with EB as a child, there wasn't even hope for just treatment on how to treat our wounds, let alone hope for a cure. So having someone like EBRP so dedicated to finding a cure is so uplifting and kind of reassuring for the future that maybe some child somewhere in the world won't have to deal with the things that I've dealt with in life. And researchers today are saying a cure is achievable within a decade. So if we rise up today, I do have hope that it will happen for the future generations to come, and hopefully sooner.
Deanna, you are a beautiful artist and an inspiration to me and all who know you. To everyone watching, please know that a cure for EB is just within reach. Researchers are working around the world and around the clock to make it happen. And when it does, we will cure EB and pave the way to curing thousands of other rare diseases. If you can, please help by clicking the donate button, texting Cure EB to the number below, or go to ebresearch.org to learn more. Thank you.
Okay, Troy, we are done.
That is great. I think I'm just going to echo what we're seeing in the chat here, which is thank you from everyone here. Everyone is talking about how much the patient testimonials mean, what it means, and how pivotal it is for healthcare professionals. So I think you've gone above and beyond with what you presented today. This is absolutely fantastic. So thank you for sharing that. I did, before we close, I wanted to bring in, I see you're there, Jeff, too, maybe just to touch on a couple of questions we didn't get a chance to get to really briefly here, if you don't mind. First, again, thank you, Perfuse MedTech, for the support today, and again for your expertise on Gecko. We did have a question I know you answered behind the scenes here. Did you want to just touch on briefly about whether you need a prescription for Gecko? Can it be, or does it have to be applied by an NSWAC doctor? I know you were always good to answer that one for us.
Okay. Yeah, good.
Yeah, I think first of all, Annie Chevre, your comment captures it best. Is that this is a true privilege, Gary? I'd never seen those that testimonial. I'm still choked up watching it. But to answer the question, Troy, it's not a prescription device. The device is very safe. It's used by professional athletes. If you're a sports fan of any sport, the sister product called Firefly is used for muscle recovery in virtually every sport. So whether it's NHL, NFL, Olympics, you name it. So it's not a prescription product.
Fair enough. And I know we're getting lots of good questions here about Gecko specifically, both in the chat and the Q&A there. Maybe if you want to let us know what's the best way, if you could do a call to action to people here, what's the best way for people to get in touch with yourself or Perfuse MedTech to learn more about Gecko?
Well, I think the easiest way is info@perfusemedtech.com, and maybe we can put that in the chat. And certainly, if you're from Ontario, get in touch with Health at Home because for some reason it was missed on the formulary. And it's a product that, clearly you saw the case study. That's not a unique case study. It's an extraordinary one, but it's not unique. The device has helped tons of patients. It doubles the rate of healing. And actually, Gary mentioned it's a Canadian product, but the interesting thing is that we cut a healing rate in half. And we just started a trade war with the US, and most of the medical devices coming into Canada are from the US. So if you want to support Canadian, this is a perfect example of when you can.
Thank you. I saw Dr. Sibbald in the background there. I just spotlighted it for you, just demonstrating what the gecko looks like. Even on the, you can see on the wrist there, just how big. It's about the size of a watch, essentially there. You can see it, and I know that was one of the questions that came up in the chat there. So what we'll do too, I know I put the email in the chat. We're going to be sending everyone here a certificate of attendance. If you'd like, you can easily just respond to that email. If you have further questions, we can help get you in touch with Jeff and the Perfuse MedTech team. And for further questions about this topic or others a part of this series, we're going to be having Dr. Sibbald again with us. It'll be in June. So we look forward to you coming on for another edition of our series. The next one's going to be in April with Dr. Stacey. We then come back again with Dr. Robyn Evans in June, and again, a second time in June with Dr. Sibbald. So for more information about that, please either reply to that email. We'll have links to get you to register for others. Otherwise, you can visit our website at nswoc.ca for any more information about the webinar series. But for now, we'll say thank you again, and echoing what everybody's saying here. Thank you, Dr. Sibbald. Thank you, Jeff and the Perfuse MedTech team. We really appreciate it, and we look forward to seeing you at the next edition of the webinar series.
Thank you, everyone.
Goodbye. Good night, everyone.